Hello and welcome to the recording on sedatives, hypotonics, and analgesics. Once again, remember the big thing with this is we're looking at just the respiratory applied component of it. We will go into a little bit of how they work and then key terms to understand when we're looking at these. A lot of the patients that we will be taking care of will have one way, especially the adult patient population, one way or another, have medications that can alter their CNS, that can alter their ability to think and process information. A lot of times we will use sedation with mechanical ventilation to help make it more tolerable for these patients. So when we're looking at this, you need to not only understand when we use them, but what are the possible side effects? What are the possible other things that we need to be aware of when we see these medications in use? When we're looking at the central nervous system, this is the CNS is the most widely used drugs affecting the CNS. These sedatives, hypotonics, and analgesics are the most widely used drugs that affect the central nervous system. So your inhaled medications, most of them, the bronchodilators, usually aren't affecting the central nervous system as much as something like a sedative, a hypotonic, analgesics, right? So this includes, it says the most widely used drugs that affect the central nervous system. This includes both therapeutics, like what we do in the hospital, and even recreational, unfortunately. So even recreational medications would go into that category. Thoughts and feelings are poorly understood when we're looking at these. So the neurochemical interactions and balance in the brain is altered with these medications. And the big thing is humans are really concerned with the process of thinking and feeling, and these medications can really alter that thinking and feeling component. We've all seen those little videos of the people that are post anesthesia or post dental procedure that have a lot of medications in their system, and they're saying silly things, right? They're altering their thinking and their feeling. And this is what I want you to think about before we get too much further, is your patients that are on mechanical ventilation. Traditionally, in the neonate world, we don't use sedation, or we try not to as much as possible to avoid messing with their central nervous system. But on the adults, to make it tolerable, we usually have to use something. And so when we're doing this, what is that patient thinking and feeling? Are they in their right state of mind, the state of mind that they would be at their baseline? They may not be, especially if they're on medications that are in these categories. And so their balance, the things they say, the things that they might do, the actions that they take, are probably altered from their baseline. So that's something you need to remember. The process of thinking and feeling is altered with these. And so if you have a patient that's on any of these medications, whether it's therapeutic or if you have a patient that is recreationally on these, it can alter their thinking and their feeling. So take that into thought. Remember, this is a career of compassion, and we're there to be compassionate, to help these people, because odds are a lot of times they can't help themselves. So we're there. You got to understand that that might not be them at their baseline, especially if they're sick and tired, hungry, angry, lonely. All those things that are going on with that patient can really alter how they treat others. So just keep that in mind as you're taking care of them. I know it's easy to get burnt out when you see this, but keep that in mind as you see these patients. The next part on here is drugs that affect the central nervous system are used for their effect on perception and mood. So these drugs can change people's perceptions and their moods, right? And then we talked about a little bit this in Intro to Mechanical Ventilation in those lectures on how the medications in there and their perceptions, there's something stuck in their throat. There could be going through things that could cause post-traumatic stress, getting poked, being tied down, having something stuck in their throat, having a bunch of alarms, waking up and going back to sleep multiple times, and hearing voices, right? All those things can really mess someone up, right? And so we're looking at these drugs can really change their perception and their mood. Hopefully they don't remember too much while they're on mechanical ventilation, but as we see this, these are things that can really affect their perception and their mood. So they may not remember things as much, but they could have easily flashbacks. And delirium is one of those things that we really have to be concerned with. And I believe in advanced mechanical ventilation, you even talk about ICU delirium even more. So how does the brain organize things? When we're looking at this, the cortex is the first one. The cortex is where you have your thoughts, your memory, your self-awareness, your personality, and your speech, right? So this is where you have those. And the perception and sensation and control of your body movement is also going to be part of that cortex. So any perception or sensations, your control, your body movement, thoughts, memories, self-awareness, personality, and speech, all those are part of your cortex. When we're looking down at the second one, the midbrain, this is a relay station for the cortex, right? Just a relay station. Primarily what we're looking at would be the hypothalamus, but the relay station for the cortex integrates and modulates autonomic function, right? Integrates and coordinates autonomic functions, right? So when we're looking at that, that sort of tells you between the cortex and the midbrain what their responsibilities are. Remember, the cortex is your thought, memory, self-awareness, personality, speech, and it gives you your perception, sensation, how you feel something. Is it painful? Is it pleasant to feel that, right? And it also is a big part of controlling your body movement. So if anything affects the cortex, can it affect your ability to be aware? Can it affect your personality? Can it affect your speech? Can it affect how you move your body? Absolutely. So things that affect the cortex have a wide range of effects. So someone that's on a medication like a sedative, hypotonic analgesic, that can affect the cortex, all those things can be something they have as an alteration. So their memories, their thoughts, their ability to speak, all those things, their sensation to, and then their ability to move around can all be altered just because that medication's in their system and altering their cortex of their brain. The medulla, or the brainstem, really is the big one that controls the breathing and your cardiovascular control. And this one will also give you your alertness as well, because it's that brainstem reaction to things, right? That lizard brain reaction, as I once heard Justin call it, right? So this controls the breathing and cardiovascular control. Your pons and your medulla oblongata are the big thing that give you your breathing control. This is where we look for with patients that we're trying to determine if they are brain dead or not. We'll do different tests to look at if their breathing is still present from their pons and their medulla oblongata. So things where we'll disconnect them from the ventilator and just give them oxygen and let their CO2 rise. If their CO2 rises by more than 10 millimeters of mercury, if it's not at a baseline of a normal level for that patient, if it rises more than 10 millimeters of mercury and they're not breathing, then that's a sign that the brainstem is no longer responding to that increase in CO2. So that could be a sign of brain death. Is that the only brain death test? No, but that's just where they're going at there, because the brainstem is what has your pneumotaxic center and your pons in your respiratory center are located, so that way it tells you how to breathe and coordinate your breathing movements. So if someone's having CNS altering medication, is it possible that it could alter their breathing pattern and even cardiovascular control and their alertness? Well, we'll talk about that. And then your cerebellum, which is that back part of the brainstem, this is what gives you fine motor control. You're using this when you're writing your notes, when you're coordinating advanced movements. I think I remember my anatomy teacher saying that Michael Jordan must have an amazing cerebellum, right? I think she had a lot of admiration for Michael Jordan's cerebellum. But this would be the one that coordinates how gracefully you move, how easily you move. And you're like, hey, I'm a klutz, I trip over everything. Well, I don't want to make a comment, but there you go. The cerebellum is how gracefully you move there. And it gives you a lot of that fine motor, that detailed, graceful, fine motor movement that you're used to. Here you see the beautiful picture of the brain. The big ones that I want to point out here are, and I'll circle them, the hypothalamus, the medulla oblongata, and the cerebellum. The cerebellum is this thing here that looks like a tree, right? And I think there is a thing called the arbor vitae, the tree of life, right? Arbor vitae. Vitae is where we get our word for vitals. Arbor, of course, tree, right? And so that's the cerebellum, and that's the one that controls how graceful that you move, right? It integrates your body's function. It controls a lot of really fine motor movements. When you're looking at your brainstem, your medulla oblongata, and your pons, right? Both of these here that I'm circling, medulla oblongata and your pons, are what controls and sends your signals to breathe, right? So that's part of your brain stem there. And then your hypothalamus up here is what we were talking about earlier, which is the one that has the cortex and the midbrain, and the midbrain is what we're looking at there. Cortex and the midbrain's right here. And so when we're looking at the hypothalamus, that's a relay station for the cortex, and that's the one that will modulate autonomic function and movement. So this is a picture of everything we were just talking about. So if you're more of a visual person, I really recommend writing out which one modulates what next to this picture, or creating your own picture of the brain and modulating what controls what. And I know there's other pictures out there too, but that might be very helpful for you. If you're a visual person, you have much better visual learning skills than just listening to my, unique voice. Then that's something that I would strongly recommend to do. That might be very helpful in being like, oh, look at how fine these branches are on the cerebellum. So that must be fine motor, and how gracefully and how pretty trees are and how graceful they are. There you go. Whatever it is that works for you. Hopefully that is an exercise that helps you if you're more of a visual learner. The cerebral cortex, it integrates all body function all together, right? The cerebral cortex, all body function all together. So this is pretty much what we're looking at. Your self-awareness, which is letter B here, it controls your thought, your memories, and your personalities. That's where you've heard case studies out there of people that have brain injuries, traumatic brain injuries, and it changes their thoughts, it changes their memories, or their ability to memorize, it changes their personalities. That's that cerebral cortex, and it's that self-awareness part. And we could even see issues with speech. I had a patient, I remember when I was volunteering as a student, high school student at a local hospital, and we had a patient who had a stroke, and he had or I think it was I think she had forgotten to take to how to speak English, and her first language was actually German. And so she could only speak German after her stroke. And it was one of those things where it was a very interesting case. But you'll see a lot of things can be altered with these brain injuries. So if you work at a facility, especially with these head injuries, you could see some of these things out there as well. But this is your self-awareness. This is your thoughts, your memories, your personalities. So those are all things that you should be paying attention to and looking at with people that have not only brain issues, but also medications that we could give these patients where they might be under those. Can it change their ability to be self-aware? Can it change their ability to remember and change their personality? Absolutely. So the person you are when you're sick, or the person you are when you're on these medications, isn't the person that you are, right? And so that's the hard part about this, is giving that patient some grace when they're acting inappropriately, is just giving them some grace, right? Are you the most pleasant person when you're sick? Are you the person you are when you might be on some of these medications? Maybe not so much. So that's something just to remember, and just give them that grace. Letter B here, or letter C, is looking at sedation and depression. So when we sedate, we're depressing this ability to, so it decreases the mental function of that patient, slows things down. When we're looking at this, the outer covering of the cerebral cortex is the gray matter that just surrounds over the atmosphere. And then when we're looking at these, we're affecting the release and the amount of the brain's thoughts and speech and self-awareness when we have patients on these. So one of the things that we have to look at is understanding, hey, these patients may not be understanding all of what we're saying if they're under these medications or under things that alter their CNS or their cerebral cortex, or if they have a brain injury. They might not understand everything we're saying. They have something that is a physical limitation at this point. And so we have to understand that going into them. So next time you get a patient that is frustrating you with the way they're acting, the way that they're doing things, just be a little aware that that could be part of that brain injury, or it could be part of the medications in their systems. They may not understand the way that you and I understand at that present moment because there's something physically going on with their ability to process information. The midbrain The midbrain consists of the hypothalamus and the thalamus, right? So both of these, the hypothalamus and the thalamus. The thalamus here is a relay station for the cortex. So this is your relay station for the cerebral cortex that we already talked about this. And then the hypothalamus integrates and automates the autonomic nervous system, right? It integrates and modulates the autonomic nervous system. So what does the autonomic nervous system do? Well, you should already know that. We talked about that in a previous one. But the big thing to remember here, or take-home point, I should say, I should stop saying big thing, but take-home point is the effects of the neurotransmitters depend on the amount released, right? If we release more neurotransmitters, then that's going to make a bigger effect on these systems, right? The type and quality of transport, the protein of the previous release, the presence of modifying substances, all can really impact the relay and the integration of that autonomic nervous system, or the coordination of that autonomic nervous system. So that can really change things. So neurotransmitters are going to play a big factor, right? If we release more neurotransmitters, if we have a previous release of these neurotransmitters, if we have modifications presently, so medications in their system, or even the efficiency to reuptake these, right? If we inhibit the uptake of these, like SRSIs, serotonin uptake inhibitors, right, would help people with different mental conditions. So there's a lot of factors, and neurotransmitters are going to play a big role. So let's look at those. So drugs that affect the CNS exert effects by interaction with neurotransmitters. So this is how the CNS medications work, is affecting the neurotransmitters. So they change the release, the metabolism, the uptake of these. If we delay the uptake of a neurotransmitter, then there's a longer lasting effect of the neurotransmitter, right? So the factors that affect release, the amount, right? If we have the amount, if we increase the amount of serotonin or dopamine or any of those medications that could be doing, that could be released, the neurotransmitters can really have a longer lasting effect if there's an increased amount. Or if we don't have enough, then that could really decrease that effect overall. If there's a previous release, we already talked about that, then those pathways are created, and then we have that ability to change that a lot faster. And then the uptake, if we inhibit or the uptake, then we're going to make the effect of that medication last longer. And these can work in specific areas of the brains. And remember, the neurons have a wide array of connections. So the main cause of side effects is really looking at the CNS drugs. As CNS drugs increase or decrease, they'll change neuronal activity, right? They'll change the activity of the neurons as you give them more or as you take them away. And that's where we're looking at a lot of side effects involved in this drug category. So the complexity of the brain and drug interaction with different areas are really going to be a big area that you have to pay attention to. Chemicals really will behave as neurotransmitters. So as we give these medications to patients, they'll act as neurotransmitters. They'll have biogenic amines, amino acids that really act as neurotransmitters. For an example, oxytocin, right? Oxytocin is one of those happy drugs, right? Serotonin is another one. Angiotensin 2, histamine, nucleotides and nucleoslides, right? And peptide S, right? So peptides, we're going to really see all these chemicals can behave as neurotransmitters and affect things. Like oxytocin is it acts as a neurotransmitter and really can help people feel different things. I won't go into super detail there, especially when we're looking at starting a labor, right? If we're inducing labor, then that's where we can see that be a factor as well. So with looking at the picture, some of you are very visual. So here is the picture, and hopefully this will help out. When we're looking at this, the neurotransmitter will bind to a transmitter protein. Neurotransmitter will bind to a transmitter protein. And that's number one here, right? And the transmitter protein is this one that I'm circling here. So the neurotransmitter binds to the transmitter protein that I just circled like 14 times there. And then it's going to have this effect here, and I'm going to change to green maybe. Then it's going to be released, right? Then it's going to be released, and it's going to be transported and binds with what are called post-junctional receptors, or they are metabolized by enzymes. So here is the first one that I circled, and it goes to that receptor site. So that's a post-junctional receptor. And then the other place I went here, the ENZ, is the enzyme, right? So that would be metabolized or uptaken by enzymes, right? So that's where those are those two parts there. Each neuron releases one type of neurotransmitter. So what happens here is it activates the receptor on the postsynaptic membrane. So it activates a receptor on the postsynaptic membrane, and that's this thing here, right? It activates that receptor on that membrane. Then you're going to have electrical depolarization, right? Electrical depolarization is happening, right? As it goes there, right? And that signal is then sent there. That dendrite receives that signal, and then whatever was supposed to happen will happen. So this is just showing how that order of operations, or how that physically happens, right? So the neurotransmitter will bind to the transmitter protein. That transmitter protein then either sends it to an enzyme that sort of traps it and eats it away and brings it back, or it sends it to the receptor, the junctional receptor, the post-junctional receptor, and then that will then cause a synaptic membrane electrical depolarization, and then you're going to have your effect. And let's say it's serotonin, right? Then you're going to have a happy effect on that patient. Hypnotics will be the first category in the CNS drugs that we'll talk about. So CNS depressants, very common out there. CNS drugs may have an effect on specific brain areas. They may change neurotransmission or general effect on the brain function. And it's very dependent on each brain area and what mental function and neurotransmitter that really will change its not only effect, but its side effects as well. So let's get into the CNS depressants. The first one here is sleep. Sleep is needed for physical and mental recovery, right? We see that with the different stages of sleep. With physical recovery and mental recovery. Physical recovery is a big component to sleep, and we're looking at non-REM and REM being the physical recovery versus the mental recovery of sleep. Most Most CNS depressants will actually prevent you from going into your REM or your rapid eye movement sleep. So if we're not getting that good mental restoration during REM sleep or rapid eye movement sleep, then that can cause a lot of neurological side effects. So we need to make sure that when we're under CNS, when a patient's under CNS depressants, that we understand that their mental recovery, their ability to reset their brain's hormones and to reset their brain is impeded significantly. Now we're looking at barbiturates, and this is the oldest group of sedatives, One way to remember that is just look at the pictures, right? Older pictures. There you go. So oldest group of sedatives, they're derived from barbituric acid, and they're replaced by what we've known as benzodiazepines. So benzodiazepines are what's replaced these. And these medications were very powerful and highly addictive, and that means that they were very prone for abuse. And what do you notice about the actors and actresses in this picture, right? Very prone to abuse and highly addictive. Except for there are special uses like phenobarbital can be used for seizures, especially in critical care medicine. So can we still use barbiturates? Absolutely, right? Absolutely. But it's not a higher use category as much as it once was. How do they work? Well, they really do depress the reticular activating system, the reticular activating system, the reticular activating system. And the reticular activating system is nerve pathways in the brainstem that connect to the spinal cord, the cerebrum, the cerebellum, and they're what mediates your level of conscience. It mediates your overall level of consciousness. So someone on a barbiturates might not have a good level of conscience compared to someone else as well. So that's something that we have to be concerned about with barbiturates. It can really change that. So if you give phenobarbital to a patient that's a seizure patient, they may not have that level of conscience as you see normally at their baseline because it depresses their reticular activating system. So that inhibits their ability really to go into good quality REM sleep. Not only that, their inability to get REM sleep can lead to, and we've seen some studies out there that show that that can actually lead to ICU psychosis, or ICU delirium is what it's called. And there's even a whole website set up to ICU delirium. All right, there's a whole website, and it's a big category to go into, and that's why we're trying to use lower and lower sedation levels out there as well, because that'll help hopefully avoid some of those deliriums. It does depress the respiratory drive, right? It does also depress the respiratory drive. So someone on a barbiturates could easily hypoventilate and develop hypercarbia, right? Hypercapnia, right? Same thing. And what happens here is they overdose, they can go into a respiratory arrest from low brain control to breathe. So it's pretty much almost a central sleep apnea type situation, right? Where the brainstem just doesn't fire the signal to breathe. Other things that you have to remember here is it can alter levels when we're looking at this, and when we're looking at it may not provide any pain relief. Notice that no is under there. It may not provide any pain relief. So it does depress their ability to be aware and awake, but by activating depressing the reticular activating system. And so obviously they won't be able to go into deep sleep, but they'll have that CNS depressant activity. It doesn't do anything to the pain response. So if they're taking it for back pain, if they're taking it for so on and so forth pain, then that's something that's not appropriate for those patients. It's not going to take away their pain. And it can alter other levels of drugs. So it can increase drug metabolizing enzymes as well and alter the effects of other drugs. So we have to be careful in this category. That's where pharmacy becomes our friend. They can really look into what other drugs would interact with barbiturate medications. So when are barbiturates used? Give me some scenarios. You're like, Derek, give me some scenarios where barbiturates are used, right? So if you're a scenario person, you like to know when things are used or what's the big picture of when we're using a barbiturate besides the seizure, right? One of the ones that we'll talk about here is anesthesia. Anesthesia is going to be a big one. And these are ultra short acting barbiturates, right? Do you want to be aware during a heart surgery where your chest has split open and all that stuff? No, you don't, right? And so that's where we're going to see these are ultra short acting, and then they'll help that patient not only have a safe procedure, but hopefully a procedure that they don't know anything about until afterwards. The next category are going to be hypnotics, and these is where we're going to see phenobarb is going to be one of the ones here. And then finally, the seizure category, right? So hypnotics in seizure activity is also going to see, or sorry, pentobarbital, not phenobarbital. Phenobarbital is the seizure ones. Pentobarbital is the hypnotic ones. So when we're looking at these, they're going to have very similar effects with barbiturates and benzodiazepines. They're both going to be depressant and psychoactive, but the biggest thing that we see is their fatality rate. Higher doses of barbiturates can lead to death, but taken alone, benzos rarely cause death when we're looking at it. So barbiturates are much more dangerous because they're limited use, and then you will develop rapid tolerance to these as well. So that's one of the other situations that you have to be careful of, is they'll have to use higher and higher and higher doses to have the effect that they're looking at. So barbiturates, anesthesia, hypnotics, and seizure control. I've seen it most personally in seizure control, but I also didn't spend a lot of time with anesthesia either. So you will see these out there in use. Just understand that they're traditionally highly addictive. They're great for short-term situations like general anesthesia or seizure activity, but they do alter your drive to breathe. They don't take away pain. And then it inhibits the ability to go to rapid eye movement or that deep restorative mental sleep. Benzodiazepines, also known as anxiolytics, right? Benzodiazepines, also known as anxiolytics, and they're used to reduce anxiety. So benzodiazepines are used for anxiety medications. They're also used as anesthetics to induce anesthesia. So they really can help you go under sedation a lot easier, more comfortably. They have little effect on ventilation or cardiac function. So compared to barbiturates, have a lot of effect on the respiratory and cardiac drive. However, these ones have little effect on the cardiac and ventilation drive. So much safer there, like we talked about in that previous slide where we previewed this. They do increase the pain threshold. So unlike barbiturates will have no pain relief. This one will increase the pain threshold, so it's more likely that they'll get some relief, a lot easier to have that relief. These ones will be used to induce sleep quality. The sleep cycles can be affected here, where it can decrease REM sleep as well. So we have to be careful of that. Even though it doesn't suppress the cardiac or respiratory drive, it can still inhibit their ability to go into REM sleep. Anxiolytics are often used for anesthetic effects. So like we talked about, they prevent conversions from short-term to permanent memory. You may not remember that you went under that conscious sedation procedure, right? You might not remember that you went under that. And so that's something that we can use to help avoid people having long-term memories of these situations. So you must be thinking, what are some commonly used benzodiazepine? And odds are you or somebody around you have heard of these medications. First ones that we'll talk about are usually the ones that will help with um, people that have other issues. Xanax, Valium, Ativan, Precedex, which I'm a big fan of Precedex for sedation because that one doesn't suppress your respiratory drive. People can be extubated and be on Precedex, which is kind of nice. When we're looking at that, it's a sedation that can be very, very well used for people that need sedation that doesn't suppress the respiratory drive. It's very expensive though, and obviously Versed and Restoril, right? So you might see these out there as well. Some of these drugs may decrease the respiratory drive with opioid issues, but anxiety really. Anti-anxiety will help promote sleep for a lot of these patients. Remember, they're very good for anesthetic inductions. So treatment in seizures or seizure prevention is a big category here. And then there is a reversal agent for benzodiazepines, and it's called Flumazenil. Let me put it on the screen. Flumazenil, right? Flumazenil. So Flumazenil, right, is a reversal agent that you could use to reverse benzodiazepines. So if someone is taking Restoril or any of these medications, or Ambien, Lunesta, Benadryl, they don't recommend that one too much, but when we're looking at these drugs, especially like Versed, Ativan, there is a reversal agent that we can use to help these patients if we need to take them out of the effects of the benzodiazepine. So now when we're looking at this, alcoholism is going to be one of the big things that we have to be very concerned about. Ethyl alcohol is a byproduct of fermented sugar. And that's going to be one of the things that you have to be aware of. It's very socially accepted, but this one can depress the CNS and the reticular activating system. So the big one to know here is these zones. I am going to ask you these. These will be asked to recover. These will tell you your toxic level of alcohol in the system. When you're at 0.02 to 0.03, you'll have loss of fine motor skills. So your ability to write, so on and so forth, those things will be impaired. When you get to 0.15 or more, you'll be in gross drunkenness. And then when you get to 0.2 to 0.4, then that's where you see your decrease in respiratory drive. So I'll circle that in red. Decreased respiratory drive at 0.2 to 0.4, and then where from 0.4 to 0.6 can ultimately result in death. I've seen patients come in. I remember having a young adult come in, and he was very, very intoxicated. His level was well over 0.6, and he had no cough or gag reflex, so we had to intubate him to help protect his airway until he pretty much recovered. So that's one of those things that you'll see out there is these different levels can be toxic to their whole body, not just the respiratory drive. Ethyl alcohol is considered a sedative and hypotonic agent, and it depresses all brain areas. So all brain areas, and that's something you have to be very concerned about when we see this. And alcoholism, really, 1 in 10 Americans really has a clustering of genes that makes them more prone to addiction, and there are out there. It is considered a terminal illness when we look at alcoholism. And we see that a lot of people really can develop a tolerance to it, And as that tolerance peaks, they can eventually get into malnourishment. They can get hepatitis, pancreatitis, enlarged heart. They can get hypertensive, right? Uh, they'll eventually have cells that are completely dependent, and they'll develop alcoholic encephalopathy, and that leads to dementia in these advanced stages. And all this malnutrition, the body choosing to process alcohol over food. It wants alcohol over food all the time, and so they'll be malnourished. And their ability to heal, it's going to be very impaired. And it takes about 15 years to go through each stage. They'll have the beginning one, which is a social drinker. That middle stage, they'll become dependent. And then you'll start to see anatomical changes like we talked about with the liver. And then later in the middle stages, they'll start to have daily drinking and evidence of withdrawals. And if they don't do that, and then that final stage, they'll be going through withdrawals, and then they'll have organ damage that occurs. Like I said, it's one of those things that is very, very, can be very terminal in a lot of patients. So you have to be careful. Even mood stabilizers are something that we have to worry about on a lot of patients, but alcohol has a lot of issues that's associated with it, and you'll see it fairly commonly, unfortunately. ETOH really happens with an abrupt withdrawal, especially after long use. And we've already talked about the different stages of alcoholism and what it does to the body, what it does to the brain. And so we have to be careful of these patients. They can go through what's known as delirium tremors, so DTs, and it 5 to 10% mortality rate from delirium tremors. It can be very physiologically damaging and stressful to these patients. So if seizures occur, and like I said, they can go through a lot of stress, and that includes seizures. If seizures occur, this is usually seen because of their malnutrition, and they're often seen due to a decreased appetite, obviously, and so they'll be malnourished. They'll have CNS hyperreactivity, hyperthermia. They'll be hypertensive, right? You can even see twitching, hallucinations, seizures. And it's usually one of those situations where we try to make sure they're on some sort of sedation even after we extubate. So if you have a patient that's ETOH, we might have to put them on a drug like Precedex, right? Going back to the benzodiazepines, a drug like Precedex, so that way they can more appropriately manage the delirium tremors and avoid the possible physiological side effects of them going through it that could eventually lead them to go into things like seizures, hallucinations, hyperthermia, hypertension episodes, or hypertension crisis. So those are very significant. So how do we deal with these patients? Well, even when we extubate them, traditionally they'll have to be on watch, and they'll have to be on these medications that help them cope. Otherwise, we could see more risks than benefits if we were to just pull all sedation off and let them go through it naturally. It can be very harsh, and it can cause more harm than good. The stages of alcoholism, I just talked about that a second ago. They really do affect the whole person, physical, spirit, mind, and each stage is around 15 years, which is what I was saying before. The beginning stage are usually your social drinkers. The middle stage, usually, the cells become dependent on anatomical changes. Later stage, they'll lead to withdrawals and daily drinking. You'll see that, and then that final stage, they're having that withdrawal and that organ damage really is significant. And in that beginning stage, they're developing a tolerance to the alcohol. Their cells are adapting to it, so they have to keep drinking more and more. In that middle stage, that tolerance peaks, and some malnourishment is already present, but they're already started in that middle stage. This stage here, the middle stage, they've already started their medical issues like hepatitis, pancreatitis, enlarged heart, hypertension especially, which would be causing that enlarged heart, are going to be some of the primary issues you see there. And in the end stage, that's that last stage there. The cells are completely dependent. Alcoholic encephalopathy is present, and they're usually in a dementia state. Can you imagine just being in a dementia state? It's very sad, right? This whole situation is very sad. All the malnutrition, the body is pretty much choosing to process alcohol over food, is what I was saying before, and that's something to be aware of in these patients. So alcoholism is a very severe case. So if you have an issue, or if you know someone who has an issue, please seek help, right? That we're literally providers of compassion, and don't ever be too proud to seek help if you need it, or to help others. Antipsychotics, moving on to antipsychotics, they're used to decrease a dopamine in the brain. So decreasing dopamine in the brain, well, actually, traditionally, they increase dopamine in the brain. So it helps the patient feel better. So these ones would be considered hypnotic. So if you're trying to figure out which category we're in, we're not in sedation. We're now in hypnotic with antipsychotic medications. What happens with psychotic disorder is, in general, is they have impaired realities. They have impaired realities, and then they have an issue here where we have something called the limbic system, and it's a complex system of nerves that are concerned with of your instincts and your mood here in your limbic system. And like I said, these medications are trying to increase the amount of dopamine in the brain, increase the amount of dopamine in the brain, increase the amount of dopamine in the brain. Commonly used medications here are going to be Haldol, Seroquel, and lithium. Lithium's an older one that you'll see out there. But a lot of these ones have a lot less side effects, like Seroquel. The side effects for these medications can be very complicated. When we're looking at these, schizophrenia, lower agitation, confusion, we can see that. When we're looking at some other things here, serotonin and norepi may be decreased in these patients, and so that could be chemical imbalances that are available. So antipsychotics are a big category of medications here, and they're trying to really impact the limbic system traditionally. Antidepressants. This is the most common psychiatric disorder. Would be unipolar depression. So depression is a pretty big one that's out there. And they're usually treated with benzos, and they're relatively safe. Antidepressants are relatively safe. They do decrease sympathetic output, so they decreases sympathetic output. And then what happens is we're looking at this because of depleted serotonin or norepinephrine situation. But when we're looking at this, common antidepressants that you might see out there, Prozac, Paxil, Zoloft, Wellbutrin, Cymbalta, Effexor, right? And the big thing might be the etiologies. It might be biological. It might be psychological, social situations, right? Antidepressants can be used for a variety of situations. In general, they're pretty safe, but they do really help a lot of people live a better quality of life. So mood stabilizers, I love the picture here. Mood stabilizers can be pretty important. They're used primarily for bipolar disorder. And we can see these, there's bipolar can be a way of mania, bipolar mania. In 1 week, you can have an elevated or an irritable mood, and then start treatment with the mood stabilizers, and they really help with patients, especially with neuralgia, which means that they have nerve damage that causes pain. So they can really be helpful in some of these patients as well. So they're really good with phases of mania and can be drug or alcohol induced. They're treated with mood stabilizers, right? If we have people with depression, or antipsychotics. Common mood stabilizers that you'll see out there are listed there, and gabapentin's one of them. Gabapentin is one of those ones that helps with seizure disorders, and it's off-label for cocaine withdrawals, restless leg syndrome, diabetic neuropathy. We talked about neuralgia, diabetic neuropathy, alcohol withdrawals. So we can see it very helpful. It's very helpful for a lot of different conditions as well. The big side effects that we have to pay attention to would be renal insufficiency, leukocytosis, polyuria, and even toxicity to it could lead to coma if we see this with this, because it has some of these drugs, especially lithium, has a very narrow therapeutic window. So we can still see toxicities with this. All right, analeptics, also known as respiratory stimulants. Analeptic, they're sympathomimetics, right? So if you want to put sympathomimetics, mimic, sympathomimetics, these are respiratory stimulants, and they increase the output of the respiratory centers. We talked about that in your pontine center of your brain, your medulla oblongata, and your pons. They increase the output from the respiratory center, and they really do help treat things like narcolepsy, even ADHA, right? Ritalin is going to be one of the drugs in that category. They even have used these for obesity. And then respiratory failure with xanthines, right? We talked about xanthines. Xanthine would be analeptic. So your caffeine citrate for that baby that has apnea prematurity, well, that would be considered an analeptic. You'll see other drugs in this category. Adderall, which is an amphetamine. You'll see methamphetamine, which is out there, dexedrine or dexamethasone. All right, so these drugs are out there. They really do help stimulate that drive, but caffeines or xanthines are probably going to be one of the ones that you'll see the most for respiratory drive as well. But you will see some other patients on these things, like they're on Ritalin or anything like that, that you could see. All right, analgesics. So these ones are really good with pain management. They can alter your patient's pain behavior, so we have to watch out with this. A lot of patients in pain chronic pain especially, might need antidepressants or anxiolytics as well. Because of that, dealing with that chronic pain, they might have other issues associated, like anxiety or depression. Anxiety and depression can easily be side effects of long-term chronic pain, so keep that in mind, right? They're not just on a bunch of medications just to be on a bunch of medications traditionally. If you were in chronic pain, could that cause depression in you? Could that cause anxiety in you if you had chronic pain issues and you couldn't participate in just activities of daily living? It might be so. So pain has been often called the fifth vital sign, although I think pulse ox is the fifth vital sign. But pain is often called the fifth vital sign. Is your patient in pain? It is subjective, and that's one of the big things to remember. Pain is subjective. It's not what you say the patient's in. Just because of your assessment doesn't show patients in pain doesn't mean they're not in pain. When a patient experiences pain, they have an input from the central nervous system receptors, and then that input will then cause suffering. They can really have a big emotional response to that pain experience. It is very tough. And that pain behavior, if it's very emotional and very severe, determines the analgesic requirements, how much pain medicine to use. And that can be altered by psychological and social and psychological factors too, as well. So pain can have a lot of complexity to it besides just that physical CNS pain receptors associated. If a person has a lot of psychosocial or psychological issues, then that could really impact their perception of their pain as well. So it's a very complex subject, something that you can't be an expert on it now, and that's why there's people that a whole class of medicine called pain control experts, right, that are out there. An analgesic, by definition, is a painkiller or any group of drugs used to treat pain. Any group of drugs used to treat pain. Any group of drugs used to treat pain. Any group of drugs to treat pain would be an analgesic. So when would you use an analgesic? Well, it's any group of drugs to treat pain. So this includes things like acetaminophen, non-steroidal anti-inflammatory drugs, opioids, and they're often, like I said, given with anxiolytics or antidepressants because these people with chronic pain usually will have an issue, not 100%, but will have issues sometimes with anxiety or depression with that chronic pain. And odds are something caused that chronic pain too that could be causing a lot of stress and a lot of disorder. The first one we'll talk about here is narcotics. Narcotics are all derivatives of opium, and it will bind to the opioid receptors. The opioid receptors are in the brain and the spinal cord. I'll repeat that again in case you weren't paying attention or were distracted by something. The opioid receptors are in the brain and the spinal cord, and these are used to treat moderate to severe pain. These ones will depress the respiratory drive. I remember there was a time when I was hurt with my back and they gave me some medication to help with that. And I remember seeing patients in our ICU in the hospital that were accidental overdoses with pain medication, right? Their respiratory drive was inhibited a little bit too much and they ended up on a ventilator. So I purposely would write a sticky note on my pill bottle that told me when the last time I took a medication pill was, so that way I wouldn't end up in front of my, coworkers on a ventilator, right? So these will alter your mental status. They can be highly addictive and are dose dependent, but that depression of the respiratory drive is a real concern here. They'll hypoventilate. I remember being in the ER with the pain, and they put me on oxygen. And whenever the nurse would leave, I would take it off. Like I said, it alters your CNS. It alters your highly functional thinking. And I would take the oxygen off and I would desaturate to like 88, 89% because I was hypoventilating, right? They gave me the medication to help with the pain. And so the nurse would come back in and tell me to put on the oxygen. And of course, me being an altered mental status would be like, I'm a respiratory therapist. I know when I need oxygen, when to, right? I didn't know, right? I knew that I was altered, but there's nothing I could really do to change that, right? So the responses are going to be a little bit different. Like I said, the action here is the brain and the spinal cord where you have these opioid receptors, and the respiratory drive decreasing is something we have to be cognizant of. So that's why you might have some hospital policies that say if a patient's on a medication like this, that they have to be on some form of oxygen, even if their saturation is at a fine level, because what if they do start to hypoventilate? Well, we need to at least give them oxygen in the meantime until we can help them ventilate more effectively. Some narcotics, how do we give it? Our narcotics can be given orally, of course, in pills, intravenously, patient-controlled analgesics. I love these, the PCA pumps. There's a lot of evidence out there on PCA pumps and how they really reduce the amount of pain that a patient perceives and the amount of medication they get. The evidence that I'm aware of as of this recording shows that patients with a PCA pump tend to use less overall pain-controlled medications, and it will lock the patient out so they can't just keep pressing the button to get more. But it decreases the amount that they have to use because it's a lower, steady, continuous delivery. It's like trying to treat a bronchospasm. Can you imagine treating someone with asthma after the severe part has kicked in versus in the early stages when it's not as severe, when it's just in the first acute stage, right? When we're doing a pain-controlled analgesic here, they can press it when they start to feel pain, not when it's severe and they can't take it any longer. And if you have to treat it something that's already severe, it's going to take more medication than if you're trying to treat something at the beginning and just smushing it. So PCA pumps are very, very beneficial as far as I'm aware of the current evidence as of this recording. More drug is needed if pain is allowed to increase between doses, and so that's why I'm a big fan of pain-controlled analgesics. Like if they have to wait, 4 hours in between a pill or something like that. And it's more effective to keep control rather than to regain control. So patient-controlled analgesics, a very big help to just the healthcare society altogether, in especially acute care medicine. There's obviously inhalation narcotics that we can use. I believe morphine is one of those ones. Morphine's a little controversial with nebulized version of it. I remember having to give it, and the big thing was to help reduce the sensation of dyspnea for end-stage COPD patients or end-stage patients that are experiencing dyspnea. So nebulized morphine would help those patients, but that research is very low quality. It's not a very highly studied scenario, so it's tough to see high quality material there. Obviously local and epidural. Locals are great, especially if they're having small procedures on like their hand or their arm. They can do spinal blocks, things like that. Or epidurals, which are great. We used epidurals not only for labor and delivery, but and they'll do spinals for epidural for labor and delivery too as well. But they would do epidurals for patients that had multiple broken ribs that were going to extubate from the ventilator. Well, are they going to have a lot of pain and difficulty breathing because they're pain, right? If you're in pain and it's your rib cage that's broken, are you going to want to take deep breaths? Are you going to want to cough? No, but if you have an epidural and you can't feel anything below your collarbone, right? Are you more likely to take deep breaths? Are you more likely to cough, right? You're more likely to have that as long as you don't have too much in your system that then causes you to hypoventilate. So there's a fine line here. But epidurals were very good use for those patients that were going to be in with multiple broken bones, and we're going to have to take them off the ventilator. And now we have to worry about their suppression of the respiratory drive, where with the mechanical ventilator, we didn't have to worry as much about suppressing their drive because they were on a machine. So a few narcotics that you might be aware about there. Morphine's one of the bigger ones. You'll see this for end-of-life care. You'll see it like I was talking about with nebulized. You'll see other medications out there. Codeine, fentanyl. Fentanyl you might have seen for them using that in other scenarios like rapid sequence intubations. Heroin, now something we usually used in the hospital, but methadone, right? We'll see that especially in babies that are born addicted to narcotics. We can use methadone to help wean that baby from narcotics to avoid all that physiological stress of trying to just withdraw cold turkey. So you'll see that even used in the neonatal ICU, the methadone, where we're giving babies methadone to help wean them off of narcotic addiction that they had from mom. Hydrocodone, oxycodone, of course, tramadol. But remember, narcotics, this is a bullet point to write down. Narcotics are reversed with naloxone or Narcan, naloxone. Will I give you scenarios where you have to remember that information? Well, absolutely, right? You should know what reverses narcotics. Local anesthetics really do interrupt the pain signals in the different areas of the body, and that's the advantage there. Epidurals really do help improve things like postoperative pain. and they can be combined with opioids as well as part of it. The big side effects here, motor weakness, so these people should not be walking around with an epidural in. They can feel really numb. They can get hypotensive, right? Their blood pressure can really drop significantly with these. So if someone already has poor hemodynamics to begin with, or low hemodynamics to begin with, it could make them worse. When we're looking at this, lidocaine, novocaine, benzocaine, those are all drugs that could be in this category, so anything in the cane family. The canes you have to watch out, like lidocaine is an amide, novocaine's an ester, so you'll see different formations out there as well. Non-steroidal anti-inflammatory drugs, or NSAIDs, they really do help inhibit the production of inflammatory mediators. So we're trying to reduce inflammation without using steroids, right? By doing that, they're going to hopefully do that at the site of the pain, and then they'll really impact that hypothalamus. These are used to treat moderate pain, right? You'll see this with Advil as well, right? Advil's the big one that can also cause gastric ulcers. But moderate pain, the side effects of these, and you probably heard this before, is Advil would be like gastric irritation, or you could even see gastric ulcers, renal injury, of course, if they take too much of it, and then low platelet production as well. Renal injury really can occur with long-term use of high doses. So long-term use of high doses, so don't think if you take Advil here and there that you're going to have renal injury, but long-term use of high doses really can impact the function of the kidney. So you got to be careful with these, even though they're over the counter. They can still cause a lot of issues and side effects. Big reactions, rashes, asthma is a big one. Asthma is a big one, and we can talk more about that in class, but or I can have you guys find out the answer to that, why asthma is a big concern with NSAIDs. Anaphylaxis is another one. Tylenol is not considered an NSAID at all. Tylenol will go through the liver. It has no GI effects, no negative GI effects. So Tylenol doesn't affect the GI system like your Advil or Aleve will. So there's a big thing there. And Tylenol is usually used for people in mild to moderate type of pain, but and Tylenol is the one that's also safe for pregnancy compared to other drugs as well. Combination therapies, these are very popular out there. One of the ones that I've seen the most was this one, Percocet, which is oxycodone and a Tylenol, acetaminophen, together. But you'll see Percodan, Vicodin, Percocet, Vicoprofen, right? These are all combination therapies that are used out there. They are better with side effects, toxicities, and half-lives overall, because we're having a synergistic effect. We might actually be using less oxycodone overall, or less hydrocodone overall, because we're combining it with an ibuprofen or a Tylenol or an aspirin, right? Because we're combining it with one of these over here, then we might be able to use less of these over here, less milligrams over there. So because of that combination, you're like, why would they do this? Well, that means we might actually be able to use less of the narcotic side, which could help that patient overall, especially avoiding things like drug dependency. Chronic pain syndromes, surgery to treat a situation like a spinal fusion, or let's say a person had an injury from a car accident, can cause an acute pain, but can acute pain also lead to chronic pain? Absolutely. And so when we're looking at this, we'll try to treat during that acute phase. So chronic pain includes hyperesthesia, right? Hyperpathia, and allodynia. So all these occur after the acute trauma, and usually it's near that nerve trunk of whatever is injured. So with hyperesthesia, That's an increased sensitivity to all sensory modalities. Increased sensitivity to all sensory modalities. So they feel hypersensitive pain to any like light touches or anything like that. Hyperpathia is the abnormal feeling from mild uncomfortable stimuli. So they just that mild uncomfortable stimuli might really affect these patients. And like I said, this usually occurs after acute trauma, and it's something that can be pretty significant, right? And then finally, this last one here, allodynia, is painful feeling from just gentle stimuli, just gentle, right? So we have gentle stimuli versus mild uncomfortable stimuli to hyperesthesia, which is all sensory modalities. So that chronic pain could be any of those three or a combination of those as well. So you got to watch out for these patients. What if you're doing an arterial blood gas on them? What if you're, doing other procedures? They could really have a lot of pain associated, even if you have to do wrist restraints during mechanical ventilation or anything like that. They can have issues there. So we got to be cognizant of these chronic pain syndromes. What are some characteristics of chronic pain, especially neuropathic or neuropathic pain? One is pain can be involved with sensory loss. They might not be able to feel or get that input to their brain from other things because they're in that chronic pain. They might feel burning, electric or shooting pain, especially with sciatica, things like that. They could easily have sympathetic hyperreactivity, and this one I talked about a lot with neuromuscular blockade agents. Just because you paralyze a patient doesn't mean that they don't feel the pain. Just because they can't move doesn't mean they don't feel the pain. It doesn't block pain receptors. It just blocks the ability for them to move. So how do I know a patient on paralytics is anxious or in pain? Well, one might see that sympathetic hyperactivity. I might see a heart rate increase, blood pressure increase, right? I might see that sympathetic activity start to go up, which would tell me that they're in pain. And then finally, they can result in skin and hair changes as well. This chronic pain can really lead to severe suffering and incapacitation. We talked about this before, where they might have more issues with anxiety and or depression as well. So chronic pain really does respond poorly to neuropathic analgesic treatments. Alpha receptor blockades can be helpful early, but overall that chronic pain can still be an issue on these patients. So we have to watch out. Chronic pain is a big issue in the especially adult patient population, and we got to understand and be empathetic as much as we can to help these patients through it. It is not a very pleasant thing that they're in that category, and we just got to be careful of that. It's very easy to judge, but compassion you have to work at. Sedation will be our next category here. You've likely seen a lot of this in your ICU rotation, so let's get started. So anesthesia is the drug-induced absence of perception. So if I'm asking you what the definition of anesthesia is, here it is. The drug-induced absence of perception. The depth of anesthesia is determined by the patient response to painful stimuli. So what they do, especially during local anesthesia for a spinal block or an epidural for pregnancy, if they go into C-section, or I've been to many C-sections, we go into there, they'll usually pinch the area of where they're going to do the C-section, and then we'll see if mom feels it. Anything besides pressure, right, that they can tell, right, by the patient's response to painful stimuli. If the patient was unable to respond, we could also see that in their change of their heart rate and their blood pressure as well. If their blood pressure and heart rate start to go up, then that's a sign that they're still aware and that they don't have the absence of perception. Monitors can also help us here. RTs are responsible for monitoring ventilation and cardiac function. So if we see the patient's heart rate, blood pressure going up, that might be a sign that their anesthesia is not appropriate. And a lot of times we'll be there, especially with conscious sedation. Conscious sedation, we have to be very concerned when the patient might have a little bit too much medication in their system and their heart rate and their blood pressure starts changing. Uh, so you are responsible for that. You got to understand that it can drop their blood pressure and it can cause them to go into cardiovascular issues as well as depressing the respiratory drive. We use anesthesia in emergency departments, ICUs, conscious sedations is a big one. We use that all over the hospital, even bronchoscopies traditionally are used with conscious sedation. How are these drugs administered? IV or inhaled, right? IV or inhaled could be an option, but every doctor is different how they're going to choose which medications they're going to use for sedation. Out there. There is a highly evidence-based guideline by the ARDS network that recommends sedation holidays or sedation vacations, right? Synonyms there, but to help those patients and to evaluate their neurological status. But they're all going to have their different forms of which medications they like to use, dosages, and so forth. So the definition of sedation is the depression of a patient's awareness to the environment and the reduction to their responsiveness to external stimulation. So depression of the patient's awareness to the environment and the reduction of their responsiveness to external stimulation. So hopefully that's going to give you a better picture of what we really mean by sedation. So it doesn't mean taking away their awareness, it just means depressing the patient's awareness to the environment. So that means they can still respond. If you go into that patient's room on mechanical ventilation that's on sedation and you squeeze their hand or you introduce yourself, they might open their eyes and look at you, but they're still under sedation because they have a depression of their awareness that they're in the ICU, but they're still there. The patient's still in there. They're still able to respond, right? But their responsiveness is depressed. Their external stimulation might be depressed. They might only open their eyes when you go to listen to their lungs, even though you already talked to them. And the big advantage here is these really do help treat pain, and sometimes they can help with anxiety. So sedation can be helpful for pain. Is it going to take away pain or take away anxiety completely? No, but that sedation could help with someone's pain or anxiety issues. So sedation may have additional beneficial effects. Anti-anxiety, so it could help relieve trepidation or agitation. That's why you might see them use this. Of course, there's the Michael Jackson situation where they were using Diprivan or Propofol, right, to help treat those patients. Other situations that you might see, it can help with amnesia, right? It can help lapse their memory, especially for short-term procedures like resetting a bone for a conscious sedation. Analgesia, it can help relieve a pain like resetting a bone for conscious sedation or fixing a burn or things like that. It can really help that so they don't remember that. Analgesia, it can really help relieve that pain as well. The adverse effects, big one to pay attention here, is low blood pressure and increased heart rate. Well, remember, if your stroke volume is decreasing, your heart rate has to increase to equate for a good cardiac output. So if you start to see their blood pressure drop, that's something that you have to be cognizant of, or make sure you're cycling that blood pressure, so that way you can treat them earlier than later. But patients with cirrhosis, you have to be careful when giving them hepatically metabolized benzodiazepines. So things that we're looking at there would be like Versed, Ativan, Valium. Those ones you got to be careful with cirrhosis patients on. A technique for using sedatives and analgesics is to prevent patient discomfort during an invasive procedure, like intubation, like conscious sedation, like bronchoscopy, right? When we're doing those things, we're helping alleviate them of their discomfort during that procedure. Do you want to remember or have the discomfort of someone jamming a tube into your trachea? Do you want to remember that of someone doing a bronch on you, right? Do you want to? No, right? And even Joint Commission has standards that must be adhered to with these. With conscious sedation, RT should understand that the sedative and analgesic pharmacology, what medications would sedate or alter these patients, because the most serious complication is airway compromise. Let me highlight that again and I'll repeat it. The most serious complication of sedation is airway compromise. The most complex situation of sedation is airway compromise. So if that patient starts snoring when we're doing a conscious sedation, what are you going to do? Are you going to put in a nasal airway? Do they have a cough or gag reflex? Are you going to put in an oral airway? Are you going to start manually ventilating that patient? So airway compromise is the most serious complication of conscious sedation. So you're that expert, you're the airway expert in the room, so make sure that you're monitoring their breathing, monitoring them for any airway compromise. So what are the standards? The standards, there have to be a presence of more than one person at a conscious sedation. Deep sedation and general anesthesia usually require the presence of at least 3 or more people. 3 or more people. So when we're seeing this, hopefully there's more than just you in the room, right? Hopefully there's a doctor, nursing staff, right? Other providers in the room as well. For both, one person is solely responsible for monitoring and recording vital signs, right? For both, one person is solely responsible for monitoring and recording vital signs, right? Yeah, that's going to be their whole job. That's how important vital signs are with this medication on board or this type of intervention with conscious sedation. During conscious sedation, you need to assess the patient's oxygenation, ventilation, and things like temperature as well. So ventilation, traditionally, this is done with end-tidal CO2, which will give you a quantitative, it'll give you an amount, right? It'll give you quantitative evaluation of how well their breathing is doing. Sedation, when we're looking at that, can also, when we decrease ventilation, it can also decrease their ability to oxygenate. So pulse ox will actually fall after they've already started becoming hypercarbic. That's why end-tidal CO2 is actually going to be more sensitive than pulse oximetry to determine hypoventilation. So ventilation, oxygenation, which usually is non-invasive with pulse oximetry, and then temperature as well, things to look at. So what do we monitor during sedation? EEGs, one of the things that we could use, especially if we're using a neuromuscular blockade. And it requires specifically trained personnel and equipment. This is the same EEG stuff is used for those patients that are seizure patients, but we'll also see this if you ever want to do sleep lab. You'll see them use EEGs during sleep lab to look at the slow wave sleep versus REM, so on and so forth. You'll see the different brain patterns there. BIS monitor, or bispectral index monitor, uses the Ramsey scale, and what it does is it's mostly used in the OR because we're paralyzing these patients. So you'll see BIS monitors for paralyzed patients, and it looks at their level of sedation, because if they're paralyzed, they can't respond to painful stimuli. You don't know how conscious they are if they're paralyzed. So the BIS monitor tells us in a rough way their level of consciousness. A BIS of 0 means there's EEG silence, whereas a BIS of 100 means that's a fully awake adult. So if we see a BIS of 40, then that usually means they're under general anesthesia. So that's one of the things that we'll be looking at there is BIS monitoring. So they'll put it on the forehead. You know, like I said, you'll most likely see it in the OR where they're paralyzed, or in the ICU where we're paralyzing a patient there. And we're trying to see how much sedation the patient has on board. So the Ramsey scale, this is the Ramsey scale. 0 means they're awake and oriented, agitated versus awake and cooperative, that 2. Sleeping but cooperative, 3. Deep sedation would be 4. Deep sedation with slow reaction to painful stimuli would be 5. And deep sedation with no reaction to painful stimuli would be 6. So that sort of tells us how awake that person's brain is when we're looking at this. And this is that picture of BIS monitoring, right? Like I said, it goes on there. And we're just looking at the level of conscious awareness that the patient has while they're on deep sedation. With procedural sedation, a short-acting benzodiazepine is usually selected, and it may be combined with an opioid, especially combining with the opioid is great for your longer procedures, and it does increase the risk of respiratory or cardiac issues like tachycardia, hypoventilation. Drugs in this categories are used every once in a while, but we're using other sedatives that are becoming more and more common. You probably heard of these, especially in your critical care class. Your etomidate, your propofol, also known as Diprovan, even nitrous oxide, your laughing gas that we use for general anesthesia, are also used as well for procedural sedation. Specific reversal agents really need to be ready when we're doing this. So especially if there's a narcotic involved, Narcan or flumenzidil, which helps with benzos, right? That's something that we're going to have to see that would be very helpful in that case. Procedural sedation drugs, so etomidate, let's talk about that one. Etomidate is ultra short acting. It is great for intubations because it is ultra short acting. And what it does is it transiently lowers cerebral blood flow by 20 to 30%. So it can actually decrease ICP and intraocular pressure. So that's a good advantage there. It does not have any pain-killing associations with it. Not any pain-killing associations with it. But it does have minimal cardiac and respiratory effects when we're looking at etomidate. So that's why you might see them use etomidate, Versed, or even ketamine for intubations. Precedex is the next one on the list. It lacks respiratory major cardiac depression. Like I said, this is the drug that I even used. I didn't use it, but it was used on a patient that was a 3-year-old on a non-invasive. Can you imagine putting a baby on a 3-year-old on non-invasive positive pressure ventilation for a couple days? Adults have a hard time managing being on non-invasive. Now imagine a 3-year-old. Well, we were able to do that with a medication with Precedex. So it can be really helpful in situations like that. Ketamine can be used with pediatric patients, is where it's most typically used, because it can cause sort of abnormal visions and things, so we have to be aware of that. But it's typically used in pediatric patients. It is found profound dissociative amnesic action, so it has sedation and anesthesia effects. It's useful when fasting is not assured. In other words, we don't know if their stomach is full or not. Cardiac or respiratory stimulation is normal, so they'll have a transient respiratory depression when we give ketamine. That may occur, so you might have to worry about them hypoventilating if we're just doing a conscious sedation procedure. Or if it's administered too rapidly, or if they give too high of a dose. I've seen that as well, but it's one of those medications that can really help out there. Propofol, also known as Diprovan. This is an ultra short-acting sedation, and it's very potent, very, very potent. There are no analgesic properties with it. but it is rapidly metabolized by the liver. So we could turn off this medication as long as they have proper liver function. We can turn off this medication and then do a neurological check on this person very quickly, usually within 5 or 10 minutes or so. So it's very quick to get out of their system, right, as long as their liver is working appropriately. It does decrease blood pressure and cardiac output, so you have to be aware if someone's hypotensive, then ketamine might be our friend in that scenario, but this one can decrease blood pressure and cardiac output. So be aware that their blood pressure might fall after they administer it. And it does have a high rate of discomfort, as it can feel like burning sensation when they give it. The duration of it in their system is usually dose dependent, but about 5 to 10 minutes, and then it will peak within 90 to 100 seconds. So this is a very potent, ultra short acting sedation, and this is one that you have to watch their blood pressures. Make sure you cycle after they give the blood pressure for that patient. So hopefully you've seen a lot of information. I know this one was filled with content, but hopefully you understand sedation a little bit better and your definitions. Hypnotics, when would you use those? Analgesics, when would you use those? Hopefully you'll remember what's the big thing about the cortex and how it is in control of self-awareness and personality and speech. And the midbrain is a relay for the cortex, primarily the hypothalamus. That your brain, your medulla, really does control your breathing and your cardiovascular control. The cerebellum does give you that fine motor movement, and the CNS is the most widely used drugs that affect the CNS. And so the way that the patients think and feel on these medications are altered. They're not themselves when they're on these type of medications. Their speech, their ability to control their thoughts, all those things are inhibited when they're on these types of medications or on these type of things. And a lot of side effects can go on with these, including affecting their speech, including affecting their long-term health, especially when we're talking about things like alcohol or abuse of barbiturates, things like that. But then again, things like barbiturates can be very helpful in seizure management, or even in babies that have too much bilirubin in their system. We can use that to help prevent a seizure in those babies or to treat a seizures. The medications in this category can decrease their ability to go into REM sleep and as well. So anti-anxiety medications and mood stabilizers, when would we use those and how do they work? Antipsychotics, when would you use those? What are some effects of those? What are some side effects? Antidepressants, when are we going to use those? What are some medications there? Especially antidepressants in line with chronic pain patients and anxiolytics. Understand how chronic pain affects patients, and understand why we're going to have to alter some of our medication approaches, and then how do we know the level of sedation a patient is on? What type of ways are narcotics administered? What's one of the safest ways narcotic is administered, as far as oral, IV, PCA pump, inhalation, epidural, locals, right? When would you use? What are narcotics reversed by? What medication reverses narcotics? What is combination therapy? What about NSAIDs? Is Tylenol an NSAID? Why do we have to worry about NSAIDs and asthma, right? When we're looking at this, what's the definition of anesthesia? What's the definition of sedation? When we're looking at this, so how do we monitor patients with sedation? When we give a patient drugs like Diprivan, what do we have to watch out for? Why would it feel uncomfortable for the patient? What would they experience? So hopefully that gives you a good overview looking at these things, and gives you a better understanding of taking care of these patients. Like I said, we use a lot of these medications in critical care, emergency care medicine, even especially talk about ketamine with kids all the way up. Take some time, write some good notes, your indications, usage, reversals, side effects, things like that. But another component I hope you got out of this is that level of compassion to these patients that have pain, that are acting inappropriately because they are not themselves. A lot of times there's something that happened to them, whether a traumatic thing or the medications they're under are impacting their ability to be their own personal self.